Good evening. My name is James Relle. I'm a physician and urologist at Michigan Institute of Urology. Thank you for attending tonight's webinar. I'm very appreciative of your time, and I hope that in the next several minutes, I'm going to give you a deeper understanding of the prostate, how the prostate affects the urinary tract, and why many of you may have or will have urinary symptoms and how we can address those. By way of introduction, I am a board-certified urologist. I graduated from Queen's University Medical School in Canada. I'm class of 1988, so I've been in practice now coming on 30 years. I did my residency and training at the University of Toronto, including a fellowship in minimally invasive urology. I would consider myself a general urologist, but I have focused over the past many years with a subspecialty interest in voiding dysfunction, meaning how the bladder works improperly, and have been aiming to try and fix symptomatology in that regard. I also have a strong interest in managing kidney stones and prostate cancer with robotic surgery. Today we'll be focusing our discussion on benign prostatic hyperplasia, or BPH, which is a very common condition where the prostate, which is a gland in the urinary tract and involved in sexual function, becomes enlarged and becomes symptomatic or causes symptoms in the urinary tract. BPH is, first of all, non-cancerous. It's very treatable, and it's exceptionally common. 50% of males over the age of 50 will begin experiencing lower urinary tract symptoms as a result of BPH. And by the time patients are in their 80s, over 90% will have BPH, which is essentially the benign or non-cancerous enlargement of the prostate gland. It's not entirely clear why this growth and enlargement does happen, but it's likely related to the complex hormonal interactions in the urinary tract. So what is the prostate and why is it a problem? The prostate is a gland. Glands are structures in the body that produce fluids, enzymes, or proteins that create chemical reactions or do chemical or biologic processes. Perfect example of such a gland is the salivary glands. We know that salivary glands produce saliva. Saliva is what starts the digestive process. Well, prostate glands produce PSA, and this enzyme is an enzyme that creates an environment where the sperm can work properly and move properly. So the location of the gland, the prostate gland, is strategic. It surrounds the first part of the outlet of the bladder. You can see on this diagram that the bladder essentially is a party balloon sized organ, which is designed to do two functions and two functions only. The bladder accumulates or stores urine, and then the bladder contracts, acting as a pump to empty that urine. So it stores and it evacuates. The first part of that passageway is the prostate gland. So think of the prostate gland as looking like a donut. If you think of a donut, there's structure to it on the outside, and the inside of the donut, where there's a hole, is actually just a deficiency of donut. There's no donut there. But in the urinary tract, that donut is the prostate gland, and the hole in the middle of the donut is where the urine starts coming through. That donut will morph eventually into a structure called the urethra, which is essentially a garden hose. When the prostate grows or swells, think of a donut growing or swelling. That hole in the middle will become compressed as the donut structure essentially narrows the hole in the middle. And that creates an impingement on the pipe through which the bladder is trying to empty. So this is a good time to talk about plumbing. So I'm going to give you a very brief plumbing lesson that I think will allow you to understand a little bit better why the prostate becomes an issue and how it affects your plumbing. So imagine watering your flower bed. In order to water your flower bed, you have to do two things. First of all, you have to open a valve. So you turn your faucet, and that releases water that's under pressure. Second thing that has to happen is you have to have a pipe or a tube, in this case a garden hose, that allows for that high pressure water to go through and aim at something. So when you turn on your faucet, you essentially create an environment of high pressure to low pressure. So the high pressure is your city water pressure, that's the source of the pressure, and the low pressure is the garden hose that has an unobstructed opening or pipe through which the water will flow. Water will only flow with that high pressure to low pressure dynamic. And the bigger the difference between the two, the bigger the difference between the pressures, the better the flow. And if you need an example of that, think of what the fire department does to get better flow through their hose. They, first of all, reduce the resistance compared to your garden hose by having a much bigger pipe. So with a bigger pipe, you have less resistance. That drops this pressure. And then they use a pumper to jack up the pressure behind that water from the city and increase the differential. So now you have higher pressure to lower pressure. And that's why you have so much better flow through a garden hose or through a fire hose compared to a garden hose. Now, imagine as you're watering your flower bed that someone steps on your garden hose while you're not watching. So you know intuitively that what's going to happen there is that flow is going to drop. And the reason it's going to drop is that your city water pressure, which is the source of the initial pressure, doesn't change. But your garden hose now has more pressure to overcome. So you've essentially decreased your pressure gradient. Instead of high pressure to low pressure, it's now high pressure to medium pressure. So this reduced gradient is what causes reduced flow. Now, if we translate that to the human body, think of either your heart or your bladder. They both function exactly the same way. Both the heart and the bladder are muscular bags that fill up with fluid, and then they act as pumps. These bags of muscle will contract, and this generates pressure to push fluid through a pipe. So Mother Nature designed both pumps exactly the same way. Now, as you get older, let's say with your heart, your blood vessels essentially get tighter. They lose their elasticity. So as you get older, you have your heart putting out this much pressure, and now your arteries, it's like somebody stepping on them. So you would normally expect that you have reduced flow. And with reduced flow, you'd have less exercise tolerance, you'd get tired, you wouldn't get oxygen being delivered to your tissues. But that's not at all what happens. What happens is a very peculiar thing that's unique to muscle. And that is that muscle gets stronger when it's stressed. The process is called hypertrophy. Hypertrophy is doctor talk for getting bigger. So when your heart gets stressed by this increase in resistance, it responds by hypertrophy and actually jacks up the pressure behind it. Imagine someone jacking up the city water pressure when someone's stepping on your garden hose. You would have unchanged flow because as the compression of the garden hose happened, your city water pressure would jack itself up, and the differential, which is what causes the flow, wouldn't change. That's exactly what happens with the heart. The heart hypertrophies, jacks up its pressure, so again, the differential doesn't change. Now, what does that mean for you? It means that you have no symptoms. What does that mean for what we can measure? Well, we measure your blood pressure, which is this number. So as your arteries tighten as you get older, your blood pressure actually goes up to adjust to increase the pressure so that the flow doesn't change. That's why people don't complain of high blood pressure when they go to their doctor, but they're discovered to have high blood pressure when we do certain testing, like checking your blood pressure. And that begs the question, well, why do you have to fix that? Well, the reason you have to fix high blood pressure is that this continued increase in strength isn't sustainable. Eventually, the pump will run out of gas and won't be able to overcome that added resistance, and you'll start to get symptoms. And the symptoms usually lead to heart failure, fatigue, and eventually death. And it's an unavoidable sequence of events to get to that stage if you don't correct the underlying problem, which in this case is the tight arteries. So that's why we correct high blood pressure, because we can't keep getting stronger and stronger with regards to the power of the heart. Eventually, it'll peter out. Well, what does this have to do with your bladder? Everything. As I've said before, the bladder is identical to the heart in its design in that it's simply a bag of muscle that will contract around fluid, in this case urine and not blood, and it will then push that urine through a pipe, a urethra, not an artery, but fundamentally they're the same. And what happens as the prostate grows is it's like somebody stepping on the garden hose, or the arteries getting tighter. And what happens as a result of that is that the muscle, in this case the bladder, has to get stronger. And it does so, because that's what muscles do, through a process called hypertrophy. The end result, higher pressure, but initially no symptoms. Now, this is what leads to what happens with the prostate and what happens with your symptoms. What are the symptoms of BPH? And I'll explain why these happen in a moment. Typically, sudden urge to urinate. Patients notice that they can't hold it as long as they used to. Difficulty in starting your flow. Patients find that they got to go, but they stand there and wait, and the urine doesn't come for a while. Interrupted or slow or weak stream. Just like somebody stepping on a garden hose, you'd expect this. As the pipe gets narrowed, the pump is overwhelmed and can't push out the urine as quickly. Frequent urination, especially at night. This is because of a number of factors, including muscle that's grown or hypertrophied isn't as stretchy. Think of a bodybuilder. He's hypertrophied, big and strong. He's terrible at yoga. He doesn't stretch. Well, the same thing with your bladder. When your bladder is overworked and fighting through increased resistance, it's terrible at yoga. It doesn't want to stretch. And because it doesn't want to stretch, it's fighting back. So you go more frequently. It also doesn't empty as well because it's overwhelmed. So it doesn't fill as well and it doesn't empty as well. So instead of emptying to completion and then having a lot of time to fill up, you're now operating at a much smaller margin. Painful or straining required for urination. When the bladder pressure is very high, you have to sometimes add to it, and that increase in pressure can be painful or uncomfortable. As I mentioned, inability to empty the bladder completely for obvious reasons, the bladder muscle becomes overwhelmed. And eventually urinary leakage, which typically occurs either from the urgency, where the bladder muscle is so hyperactive that it doesn't allow you to fill up and it starts to overwhelm the control valve, or the fact that you go into what's called overflow incontinence, which is like a coffee pot where you keep putting coffee into it even though it's filled to the brim. It now starts to spill over. Complications of BPH, urinary tract infections. The body's way of helping itself protect against infection is to evacuate fluid chambers. So every component of the body that has a cavity can protect itself against infection by draining that cavity. So when your hair follicles, for instance, which are little ducts that secrete oily lubricant, when they get plugged up, you get an infection. Those infections are affectionately known as zits. But it's the same process. A plugged cavity gets infected. When bladders don't empty properly, they get infected. You can also get bladder stones. Bladder stones are the result of all the elements that are in the urine. The urine contains calcium and oxalate and other factors that can crystallize out if the urine is sitting around and not moving properly. Back pressure. Everything is connected to everything else in the body. So the kidneys drain into the bladder. Imagine that bladder as being under high pressure. That pressure backs up into the kidneys and causes them to fail. Urinary leakage or incontinence, as we've talked about, and ultimately bladder failure. Just like congestive heart failure is the unavoidable eventual outcome if you don't treat the high pressure. Same thing happens in the urinary tract. If you don't treat the high pressure, the bladder will fail and you'll go into urinary retention. BPH has nothing to do with prostate cancer. These are two entirely separate elements. They have nothing to do with each other except for the fact that they both arise in the prostate. Think of it as breast cancer and breast size. They have nothing to do with each other, but they both occur in the breast. So, how do we go about, first of all, diagnosing BPH? Well, a thorough history and physical will lead me or any of my colleague urologists to suspecting that a patient has BPH. To investigate, the first thing we typically do is we feel the prostate to get an idea of its size, and also to exclude prostate cancer because we want to be thorough. Second thing we do, in addition to this, is do a PSA because this also helps us screen for prostate cancer. Again, prostate cancer is very common, unrelated to BPH, but we want to exclude that first because the two elements are treated differently. Next thing we'll do is a urine test looking for any evidence of infection, red blood cells, or kidney damage, such as seeing protein in the urine. And finally, a very simple test that we can do in the first office visit is a bladder scan, which actually we do after a patient's urinated to see how well or not well a patient is actually emptying their bladder. It's a very good initial screen for bladder function. Next thing we'll do is non-invasive testing of bladder function. Again, using the analogy of the cardiovascular system, because again, the two systems are very similar in terms of their plumbing and design. One of the easiest tests that we do to check how well your heart is working or what kind of situation your heart is under is by checking a blood pressure and by checking a pulse. So the pulse reflects flow, and the blood pressure reflects how much strain the heart is working under to pump that flow. Urologically, we can do exactly the same thing. A test called urocuff is the equivalent of a blood pressure check, except on the urinary tract. And what we do is, through a variety of testing technologies, we can have a patient come and do a urine flow study with a device that actually measures pressure non-invasively. If we get a little bit more creative, or we need to get a little bit more information, we can do minor invasive procedures called urodynamics, which involves placing a tiny catheter about the size of a spaghetti noodle directly into the bladder and measuring pressures that way. It's a harder sell, I'll admit that, than a urocuff, which is non-invasive, but sometimes we need to go the extra mile and get a little bit more defined testing with the urodynamics. An additional piece of the puzzle is to do an ultrasound to evaluate the prostate size. Prostate size is important because there are various different techniques and technologies, which I'll talk about momentarily, that can be modified based on the size of the prostate, because different size prostate can be treated through different modalities. The final part of the significant testing is the direct visualization of the urethra. We need to know what your pipe looks like from the inside before we can give you a comprehensive summary of what options are available to fix it. So an example, if a patient has a scar or a narrowing that has nothing to do with the prostate, we need to know about that before we start treating the prostate, because it may very well be that the scar is actually the problem and has nothing to do with the prostate. So cystoscopy allows us to define the urinary anatomy from the inside much more accurately. Second thing is we can exclude things going on in the bladder that we would need to know about. An example, a bladder tumor or a bladder polyp can mimic some of the irritative symptoms, and we need to know if there's a tumor or polyp in the bladder. We also need to know if there's stones in the bladder, because again, those can be eliminated and often resolve many of these symptoms, and then we can work on managing the cause of those stones at a later date. Advanced testing, as I mentioned, transrectal ultrasound is something that I almost invariably do in order to get a full and comprehensive evaluation of the exact size. And if needed, if I'm worried that there may be underlying cancer in addition to the benign enlargement, we will do prostate biopsies to exclude cancer, because again, cancer is managed entirely differently than managing benign obstruction. There are a variety of treatment options, and these range from minimally or even non-invasive to more invasive. So we'll talk about these in brief succession: lifestyle changes, medication changes, prescribing medicines to counteract some of the effects of the prostate, and ultimately procedures. And there are a variety of procedures going from minimally invasive to more invasive. So let's talk about lifestyle changes. Some of these may seem painfully obvious, but it's remarkable how frequently we have to advise patients of this. Patients complain to me often as a major complaint that they wake up 2 or 3 times a night. When I review their fluid output at night, I notice that they're peeing 1 to 2 liters a night. So I asked them, how much do you drink before you go to bed? I said, well, my doctor's told me that I should stay really hydrated, so I drink 2 or 3 cups of tea before I go to bed. It's always herbal, so it doesn't keep me up. But I'm drinking, let's say a pot of tea in the evening before I go to bed. Well, what goes in must come out. So if you're drinking a lot before bed, it's no surprise that your kidneys are going to filter that and pump it out into your bladder. And your bladder is doing exactly what it should, which is to fill up and then empty. So make sure that you're not overly hydrating yourself before bed if your main complaint is that you're peeing a lot at night. Second thing is avoid stimulants of your bladder. There are essentially 4 drinks and 2 foods that will trigger your urinary nervous system nerve endings in the bladder and accentuate the need to urinate. Coffee, tea, alcohol, and soda pops are the drinks. Spicy foods and chocolate are very common food products that also stimulate the nerves. When I say stimulate the nerves, think of an analogy that you're probably very familiar with. Imagine popping a peppermint into your mouth and finishing it off. What you experience after that is every time you breathe in, the air feels much colder. Well, you clearly know that the air temperature hasn't changed since you've eaten the peppermint, yet it feels cold. So how do you explain that? The peppermint has a stimulatory effect that upregulates the nerve endings that sense cold in your mouth. So it essentially tricks those nerves into thinking that instead of being 70 degrees, it's actually 30 degrees. Well, it's clearly not, but your nerves think they are. Well, spicy foods, chocolates, alcohol, etc., do exactly the same thing. And caffeine is really the number one culprit for this, but acids and other factors within these drinks do the same. They stimulate your bladder nerves. Now, your bladder nerves don't sense hot or cold. What they do sense, however, is fullness. So if you have caffeine or coffee products and that stuff goes out of your kidneys and gets peed into your bladder is going to feel like it's got 400 cc's in it when it only has 200 cc's in it. So your bladder is going to be tricked into thinking that you have a fuller bladder and that you have to go more frequently. So modulating how much coffee you take in, or at least recognizing that coffee will stimulate these symptoms, will allow you to regulate how annoyed you are by your symptoms. And many of my patients say, I need my 2 cups of coffee in the morning, so I know now that it causes the frequency that I have every morning, but I need my coffee and I'm willing to put up with it. And just recognize that none of these foods or drinks cause pathology, they just cause annoyance of your symptoms. So you can take them safely, but understand that they will accentuate some of your symptoms. Now, there are certain medicines that will amplify the impact of an enlarged prostate and the obstruction that that causes on your urinary tract. So the most common drugs are drugs that will either tighten your prostate and tighten the urinary tract or weaken the bladder. So again, remember the dynamics of a weightlifter, okay? A weightlifter, if he needs to lift his maximum weight every time he lifts a weight, everything has to be perfect for this. He can't be taking a muscle relaxant or something that weakens him. He can't have the flu, which will weaken his muscles. So anesthetic agents, narcotics, or medicines that have as a complication smooth muscle inhibition will essentially weaken your muscles. So that's why patients, for instance, who have surgery often go into urinary retention or notice that their urinary flow slows down because their bladder is working at maximum capacity, and now you weaken the bladder with anesthetic agents or pain medicines after surgery. Well, if you weaken a weightlifter, he can no longer lift his maximum weight anymore. Similarly, if you add weight to the barbell on a weightlifter who's already lifting his maximum, he can no longer lift it. He's overwhelmed. So when you take a decongestant, which tightens the urethra, that's part of the way it works. It's an alpha agonist or a stimulant of the alpha nerve receptors. And decongestants during allergy season are a number one culprit of this. You will essentially add resistance to your pipe, and that will overwhelm your bladder. So it's very common for me to see patients in the spring and in the fall during allergy season, at both ends, coming in complaining of a worsening of their symptom. And I often will ask them, have you been suffering from allergies and are you taking decongestants or have you had a cold lately? And they said, yes, I took Claritin D. Well, it's like, well, if you look on Claritin D, there's a big disclaimer saying if you have prostate symptoms, don't take it. And that's why. Now, how do you treat prostate-related symptoms with medication? Well, the mainstay of treatment are alpha receptor blockers. Alpha receptors are very rich in both the prostate and the bladder neck. So this is where the bladder funnels into the prostate, and the length of the prostatic urethra. These nerve endings cause tightening of the urinary tract in that area. Alpha blockers will relax that tightening. So you essentially are taking weight off the barbell and unburdening the bladder. So your flow will increase. It's like releasing pressure on your garden hose. They don't shrink the prostate, but they have a pretty good effect on relieving symptoms due to the tightness. A second class of medicine will actually shrink the prostate. These are called 5-alpha reductase inhibitors. The prototypes for these are Proscar and Avodart. They, by way of hormone manipulation at the level of the prostate cells, will shrink the prostate by about 20%, and that has enough impact to relax resistance to flow. And over a period of about 6 months, you'll see shrinking of your prostate and some symptomatic relief. Now, generally speaking, we only give the prostate shrinking medicine to patients who have a documented prostate of 40 cc's or more. When medical management either isn't tolerated or doesn't work effectively enough or loses its luster and starts to not be as effective, or if patients just get sick and tired of taking pills every day, we then have to resort to procedural interventions. And again, the mainstay of these treatments, or the main philosophy of these treatments, is to reduce resistance to flow. Again, remember, your bladder is operating by compression and generating pressure. You want to have less resistance in the pipe. So all of these procedures are aimed to do that. Let's talk about the UroLift system. The UroLift system has been in common practice now in the United States for approximately 8 years. UroLift is a minimally invasive way of opening up the prostate without any cutting, without permanent damage to the prostate, and with preservation of urinary and sexual function. It's a very novel way of opening up the prostatic urethra and essentially taking your foot off the garden hose to improve the flow, and with it relieve symptoms of BPH. The advantages of it are that it's purely outpatient. There's no overnight stay. It's a brief procedure. I can do a UroLift procedure, and I've done probably 400 to 500 of these now over the last 5 to 7 years. This procedure takes me all of 5 to 10 minutes to do. It's very quick. It's typically done in a surgery center. It can be done in an office. And in 90% of the cases, I elect not to leave a catheter. Very few side effects to the procedure. Most patients, if they have complaints, it's in the first week they have irritative symptoms. This is akin to, let's say, putting braces on your teeth for the first time. When you put braces on your teeth, there's a very sudden change in the tension on your teeth. The teeth start to move because they're under pressure, and you're on edge for the first several days until your body gets used to it. Same thing with the UroLift. It's a very similar concept. In general, bleeding stops within 24 to 48 hours, and the bleeding is generally fairly minor. And because there's no death or heating or destruction of tissue, there's very little recovery required with this. I tell patients that as soon as the bleeding stops, they can virtually immediately resume normal activities. So it's a very fast response. It's a very effective treatment. And in the majority of properly selected cases, you get very robust and very good symptomatic relief. The visual in the schematics is fairly clear. You have a prostate, the line in the middle, I think you can see my cursor here. The line in the middle of step 1 here shows that the prostate is essentially compressing the scope, which is that white tube in the middle of the prostate. On the second step 2, you can see the white tube is now angled and pushing the prostate to the side. So think of compressing foam rubber. You compress the foam rubber, and holding that telescope against the wall of the prostate, you can now fire in a stitch, which is essentially like firing in a nail gun. And that nail or the stitch will hold that prostate retracted on itself. And if you do this in 4 different locations, in about 90% of the cases, we can pull apart the prostate and open it like stage curtains and keep them open. And the nice thing about this is that it has a very durable and safe response rate, and highly effective with minimal trauma. It can be repeated if necessary, and it doesn't preclude any other prostate treatments if a patient's not satisfied with the end results or needs further treatment down the road. A second minimally invasive procedure is Resume. Resume is a steam treatment, which is a way of thermally destroying tissue. Heat is a very powerful destructive tool, and Resume essentially takes advantage of short bursts of steam under pressure for about 9 seconds. Steam is introduced into the prostate under local anesthetic in an office-based procedure through a tiny little cobra fang type device that gets popped into the prostate gland in strategic locations, and the tissue gets steamed for 9 seconds, and it almost immediately starts to die. The cells die at 70 degrees centigrade, which is just short of the boiling point of water, and the prostate will essentially first swell and then shrink as the tissues die off and then shrink away. The benefit of this procedure is that it takes a very short period of time. It's generally quite easy to do in the office setting, and it is effective. The downside of it is that it takes a while for symptoms to improve, typically anywhere from 6 to 12 weeks. There's not an insignificant recurrence rate as the prostate grows back, and you generally do have to have a catheter for between 3 and 7 days. And a lot of patients are kind of leery about having a catheter put in, and this procedure really does require a catheter because your prostate does swell quite dramatically in the first couple of days because of the cell breakdown from the heat. Corotherm is a variation on a theme. Again, as we talked about, heat is a very good destructive force. So corotherm is a way of generating heat through microwave technology with a catheter that's equipped to be placed into the prostatic urethra and then turned on, generating heat that gets spread into the prostate gland and will essentially materially heat up the prostate to between 50 and 60 degrees centigrade and effectively shrink the prostate, again, requiring a catheter because of the initial swelling. The catheter typically stays in 5 to 7 days, and then the shrinkage occurs over several weeks following. It's a one-time treatment, generally quite effective, but again, prostates will regrow, and the result isn't quite as predictable as other options because, again, it's essentially a blind procedure, and the targeting of the procedure of the heat treatment isn't that exact. Green light is another way of vaporizing tissue. This is more in the realm of tissue removal. The green light laser has the ability to superheat prostatic tissue by way of laser energy, and that laser energy essentially vaporizes prostate cells. This is done under direct vision. There's good evidence that it effectively treats and sculpts the prostate in a much more predictable way. My general peeve with this is that it really doesn't offer a materially dramatic improvement over a standard TURP procedure, which I'll describe in a minute. And there's fairly high incidence of urinary frequency and irritative urinary symptoms after the procedure, which in many cases can be prolonged. And I have gravitated personally away from using this because of that, because I find other treatment options in my hands work better. It's a very commonly used treatment. The patients or the physicians who promote it or who like it do so because there's generally a little bit less blood loss and less hospitalization than with other procedures like a TURP. But again, it's very much, from a fundamental standpoint, very similar to a TURP. TURP is short form for transurethral resection of the prostate. This has universally been the gold standard for decades. Every single minimally invasive procedure that comes to the market has to be compared to the TURP in order to be generally approved by the FDA and validated in studies. Everything from Urolift to microwave treatments to green light has always been compared to the TURP because, again, the TURP works predictably and effectively. It can work in almost any size prostate. It's highly effective and it's very immediate because you're actually physically removing in front of your eyes the prostate tissue that's blocking the urethra. The treatment is generally done in under an hour. It generally does require, or at least certainly patients are better off, in my opinion, staying in hospital overnight for observation. Why? Because there's bleeding associated with the procedure that often requires some nursing management. That nursing management is called continuous bladder irrigation, and that's generally typically only able to be done in a hospital setting, where we flush the bladder continuously for about 12 hours to make sure that no blood accumulates in the bladder and clots in the bladder to plug a patient up. Once that bleeding stopped by the morning after the TURP, generally patients go home, and a catheter stays in for a total of 48 hours on average. Once the catheter is removed, generally the patient voids very effectively immediately after, and the proper and full healing takes place over 2 to 3 weeks, wherein the bleeding risk then greatly diminishes after that, and patients are allowed to resume normal activity. I would say the biggest downside to a TURP that patients complain about, if they complain about anything, is the ejaculatory changes that occur after a TURP. There's a high incidence of retrograde ejaculation, meaning after climax, patients have, as I like to say, nothing to show for their effort. There's no ejaculate volume, and this can be a game changer for some men. I would say that the majority of men who opt to have a TURP, by the time they do that, have such significant urinary tract impairment that they really don't care about that inconvenience of reduced ejaculate volume, and are much more inclined to do the procedure to get symptomatic relief for their prostate symptoms. But at any rate, it is something that can't be discounted as having an impact on some men, and so it has to be made. Patients have to be made aware of this. Again, bleeding in the urinary tract for a period of anywhere from a couple of days to 2 to 3 weeks intermittently is something that does have to be alerted to the patients, because it can impact their post-operative activity levels. The next level of treatment is aquablation. Aquablation has been heavily marketed and very effectively marketed, I would say, over the last year. Aquablation essentially is using high pressure water, which has really in industry tremendous use. High pressure water is a tremendously powerful tool. You can cut steel with it. And this is a focused high pressure water cannon that can ablate or vaporize prostate tissue. It's done with ultrasound guidance through a transurethral approach. It does happen in the hospital. It's essentially a TURP on steroids. The upside is that it can vaporize a significant amount of prostate tissue in a short period of time. The downside is essentially that it really is just a TURP, but it doesn't have any effect on bleeding, meaning that there's no coagulation with this technology. So what you have to do is you do the aquablate, you remove the instruments, and then you immediately follow it with your TURP instruments, and you essentially perform a mini TURP to cauterize and stop the bleeding afterwards. So my personal use for aquablate, and I find it very useful for very large prostates, is to debulk the prostate with the aquablate, because it does it very quickly, and then follow up with a secondary TURP when you have much less tissue to then shave away. And that leads to a very effective sculpting and opening of a very large prostatic obstruction and eliminates it. The same side effects as a TURP are present with the aquablate, with the additional problem of more bleeding. So that's why, again, a TURP has to be done routinely after the aquablate in the same setting to minimize that risk and return it back to a more acceptable normal risk. The final piece of the puzzle is the open or robotic procedures called simple prostatectomy, which is where you remove a prostate the old-fashioned way, which used to be with a finger, essentially scooping it out the way you would imagine take your finger inside a grapefruit and get rid of the pulp and leave the grapefruit rind intact. This procedure, I would say, is much less frequently used nowadays with all these new technologies, but it remains an option for patients who have really big prostates who you don't feel that you could manage effectively with the other techniques. Side effects can be sexual dysfunction, can be excessive bleeding, can be increased hospital stay, and can be incontinence, none of which are horribly uncommon with the bigger prostate procedure. It's a much more involved operation. I hope I've introduced you to Plumbing 101 in the urinary tract in a way that makes it a little bit more understandable. I'm certainly willing to entertain some questions, and I'm happy to address some of these as they come. So let's go with some of the common questions that we see. Does UroLift need to be redone, or is it a permanent fix? Well, unfortunately, none of the procedures that we do for the prostate are permanent fixes. The prostate has this nasty habit of just growing. And it's kind of like your shoe size, your nose hair, and your ear hair. It just keeps growing. We don't know why, and it's a pain in the butt. And so any of our procedures might have to be redone. UroLift itself is very effective in the right setting. And these are factors that we sometimes don't know ahead of time. We can certainly screen effectively by measuring the size of the prostate, making sure it's not too big, looking at the prostate directly with a preoperative cystoscope to make sure it's the right shape. And even when we do that and we think this patient's a slam dunk for a UroLift, what we find when we actually are doing the UroLift is that the integrity or the material that the prostate is made up of, which is very different from patient to patient, doesn't hold the stitches as well in some patients as it does in others. So think of putting a nail into a board. If your board is hardwood versus softwood versus rotting wood, that nail will hold better in some woods than in others. And the same with the UroLift. So when your UroLift is retracting your prostate, and then that prostate sort of sucks in the UroLift into its tissue, into the body of the prostate, because it isn't that resilient a tissue. It's more like mashed potatoes than it is a raw potato. That retraction of the nail head into the prostate will lose some of the pull that it has on the prostate, and the UroLift can fail over time. UroLifts can be redone, however, to add to the retraction, or in cases where it's clear that the UroLift just isn't right for the patient. As I said before, the other minimally invasive techniques, including a shaving of the prostate, are not precluded by having done the UroLift. So the UroLift still leaves the door open for other procedures. There was a question which I think is important to address, which is the use of medicines for overactive bladder, such as Myrbetriq or oxybutynin or Gemtesa or Vesicare. These are drugs that some of you may be familiar with for the irritative symptoms: frequency, urgency, urge incontinence. Now, as we talked about before, and this is Plumbing 101, remember I talked about how you can have irritative symptoms from prostate. Why do you get irritative symptoms from an enlarged prostate? Well, again, think of what happens to a bodybuilder who lifts weights for a living, who stresses his muscles repeatedly. Okay, his muscles are stressed and they default to contraction. And that's why he walks down the street like an ape, and he doesn't walk down like we do, where our arms are dangling by our sides. His body, his muscles want to contract because they're always so stressed from all that lifting. He's terrible at yoga. You try to stretch a bodybuilder, his muscles fight back. He cannot stretch. So the bladder is the same way. When the bladder is overworked by having to fight against resistance, it's terrible at stretching and it wants to fight back. So you have frequency, urgency, and urge incontinence. Now, if a bodybuilder or a weightlifter wants to get better at yoga, and you decide, oh, I'm going to be very smart, I'm going to give him a muscle relaxant to allow his muscles to relax. Well, yes, he may get better at yoga, but you've essentially undermined his ability to lift weights because you've weakened his muscle. That's what these muscle relaxants do. The overactive bladder drugs are muscle relaxants. So they work at relaxing the muscle, but they also weaken the muscle. So now what you've done is you've essentially hamstrung the bladder, in this case, and allowed it to be weakened so it can no longer pump effectively. So you have not changed the resistance on the barbell here, but you've weakened the muscle at the same time. So Myrbetriq in the setting of persistent obstruction is not a good idea. In fact, it may be very counterproductive. And the reason why Myrbetriq often fails is that you've essentially brought Peter to pay Paul. You've weakened the bladder in an attempt to try and get it stretchier, but by weakening it, you've now compromised this function. So you may have even made the problem worse. So what you have to do first and foremost is take weight off the barbell. You have to reduce the burden on the bladder, not have it work as hard. And then let's say after you do a full urolift or a full TURP or an aquablate or something to relieve that resistance, now you can try the Myrbetriq to see if you can further improve the symptoms if needed. I failed to mention, and this is an important one, PAE. PAE is prostatic arterial embolization. This is a new concept. I would say over the last 1 to 2 years, this technology has gained a lot of traction. We are actually offering it through MIU. It's a vascular procedure where we utilize the skills of a interventional radiologist, and we do the opposite of what a cardiac catheterization does to your heart vessels. When you think of a cardiac cath and a stent placement, you are feeding a small little tube through your wrist into the cardiac vessels, and you're opening them. Well, to treat the prostate and its excessive growth, we can do the opposite. We can feed a tiny little catheter into the arteries, and there's 2 of them supplying the prostate, and we can plug them up. So instead of opening them and getting more blood supply, we're plugging them up so that you starve the prostate of blood supply, and that will shrink the prostate. The American Urologic Association has recognized this as a promising and new technique to deal with BPH. I think the jury's not out yet, but the technology proves to be very promising to the point where we have endorsed it and have worked with our colleagues in interventional radiology to begin treating our patients in this way. And I think time will tell if this is a game changer and home run, or whether it's just one of a bunch of potential options that we can utilize to shrink the prostate in a minimally invasive way. But there are certain conceptual things about PAE or arterial embolization that are very, very attractive for a variety of reasons, including if eventually you need a procedure on your prostate to have less bleeding associated with it after an embolization has been performed. Another question which I think merits attention is, does weight loss affect your BPH or affect your urinary symptoms? And the answer to that is no and yes. So it does not affect BPH and the fundamental plumbing issues, but what it does affect is what's sitting on top of your bladder. So if you think of your bladder as sitting at the bottom of a funnel of bone, so imagine a funnel, and at the bottom of that funnel lies your poor little bladder. Now, everything on top of that is essentially your bowels. So guys in general put on their weight in their gut. So guys out there with big bellies, all that weight that you're carrying on your belly is essentially sitting on your bladder. Now imagine trying to inflate an air mattress, all right? You sit there and you start blowing on your air mattress, all right? Now, that's fairly hard to do. You need good lungs for that, but it's doable. Now have somebody lie on that air mattress. Very hard to now inflate that air mattress. So think of your poor bladder. It's trying to fill up with urine, and imagine a ton of fat sitting on top of it. That bladder will not be able to stretch and fill up because you've got too much weight sitting on it. And so the more weight you got in your belly, the more weight is sitting on your bladder, the less capacity your bladder will have, and the more frequency you're going to have as a result of that. And in addition, when you cough or laugh or contract your abdomen, all that blubber is now pushing down on top of your poor bladder, and the control valve is being overly stressed. So it's not unusual, and this occurs in women as well, that your control valve can get overwhelmed by excessive weight sitting on top of your bladder. All right. Final question that I have here is, how common is scarring from a catheter, and what is the best procedure for scarring? Scarring is our friend and scarring is our enemy. And this is one of the wild cards in any surgery that you do. For instance, plastic surgery gone bad, where you create an incision trying to, sculpt a prettier face or better breasts, and the resulting scar is very unsightly. Well, scar healing is a wild card, and the same occurs in pipes and tubes. The problem with scarring in tubes is that unlike a scar on your skin, which heals side to side and gets thinner over time, and that's the nature of scarring. Scarring contracts with time. When you have scarring in a pipe or a tube, that scarring constricts the pipe or the tube as it occurs. So if you have damage to your urethra as a result of instrumentation or procedures, that scarring will result in a constricted tube. And it can be a real problem because your bladder couldn't care less whether it's obstructed from a big prostate that's squishing the pipe or a scar that's narrowed the pipe. All it knows is that it has to overcome more resistance. And so scarring can be a real problem. And scarring is correctable by a couple of different techniques: dilation, cutting, or ultimately formal surgery to remove it. Each of these procedures is more and more involved. But it can be very tricky, and it can be really a problem for patients and for physicians managing it. We're lucky in our practice that for those patients who have really bad scarring, we have a couple of experts who have done fellowships in this particular domain, and we can help you with that if that becomes a major problem for you down the road. I hope this has been helpful for you. I thank you for your attention. I know we had a very good turnout tonight on the webinar. I'd encourage you strongly to see either myself or any of our colleagues at Michigan Institute of Urology. We have in excess of 40 doctors in our practice, many of whom are prostate and urinary tract experts who don't just deal with cancer, but who deal with voiding dysfunction and the prostate. So don't be shy, look us up. We'll be happy to have one of our colleagues see you and evaluate you in the manner that we described earlier in today's session, and hopefully look out for you and your best interests and help you relieve those annoying urinary tract symptoms. Thank you all for your attention, and I hope you all have a good night.